glaucoma. We'll go through the definition once again. Glaucoma is a group of disorders characterized by a progressive optic neuropathy resulting in characteristic appearance of optic disc and a specific pattern of irreversible visual field effect associated with or without raised intraocular pressure. Secondary glaucoma, on the other hand, is a group of disorders in which the raised IOP is associated with a primary ocular or systemic cause. So it's not a primary glaucoma, it's a secondary glaucoma. We'll go through the two different types of classifications for this. One is depending on the mechanism of rise in intraocular pressure, which is secondary open-angle glaucoma or secondary angle closure glaucoma, while the second classification is depending on the causative primary disease, which includes either due to the lens, which is lens-induced, due to inflammation or uveitis, which is inflammatory glaucoma, because of pigment release in the anterior chamber from the iris. That's called pigmentary glaucoma. Then we have neovascular glaucoma, and you get neovascularization of the iris leading to angle closure. Then you've got glaucoma associated with iridocorneal endothelial syndromes, and endothelium grows over the trabecular meshwork. Then we've got pseudoexfoliation glaucoma, where you get fibrillary material growing on the surface of the lens. We have glaucomas associated with intraocular haemorrhage. We have steroid-induced glaucoma, traumatic glaucoma, Glaucoma-in-aphakia, glaucoma associated with intraocular tumors, and ciliary block glaucoma. So that is a broad classification. So there are a lot of secondary glaucomas, and which will be interconnected with different topics in ophthalmology, but we'll go through each of them and try to make things clear for you. Lens is a very important structure, and I think cataract is something which is asked very frequently in examinations as well. So the lens-induced glaucoma can be either due to secondary angle closure, or lens-induced can be secondary open-angle glaucoma. So in one, the angle is closed, in which you have Phacomorphic glaucoma, in which the actual lens becomes bigger in size, and then you've got Phacotopic glaucoma, where the lens is subluxated or dislocated. Then you've got the open angle type, where actually the lens does not cause any problem to the surface of the iris in the angle, but particles from the lens tend to clog up the trabecular meshwork. We go on to Phacomorphic glaucoma. So the cause is an intumescent lens. Intumescence means the lens is becoming thicker in size, so it is pushing the iris forward, especially at the root of the iris, thereby causing closure of the angle. It can also be caused by anterior subluxation or dislocation of the lens and spherophakia, which push the iris into the angle. So it's the swollen lens pushing the iris forward and obliterating the angle. It presents with acute congestive glaucoma and shows features of acute primary angle closure glaucoma. So that has been important, that it's a disease which is of urgency. It needs to be resolved on an urgent basis. So here you can see the Phacomorphic glaucoma. The lens is whitish in color, and it tends to be swollen and pushing the iris base forward. The treatment obviously is medical treatment. You control by intravenous mannitol, systemic acetazolamide, and then you give them topical beta blockers. Topical pilocarpine is controversial. Some people will use it, especially I think it's important in early stages when the attack has just started. If you give it with pilocarpine, the pupil constrict and the attack is resolved, and then you can do a laser iridotomy to make that connection between the anterior and the posterior chamber, thereby neutralizing the pressure or relieving or maintaining the pressure at a normal level, and then you go for cataract extraction with implantation of a posterior chamber intraocular lens. The important thing is, in these patients, you'll get a lot of uveitis post-cataract surgery. So you have to be very quick in your surgery, and then you can use some anti-inflammatory agents like intracameral steroids for that. Next, we go on to phacotopic glaucoma, which is induced due to a partial subluxated complete dislocation of the lens, which blocks the angle of the drainage. Here you can see this is the clear lens, which is actually subluxated in the anterior chamber and is blocking the anterior chamber in this area. So the treatment of this thing also remains medical treatment. And all because it's an acute attack, you control the intraocular pressure by IV mannitol or systemic acetazolamide and then give topical beta blockers. And what you typically would do in these patients is plan for surgery as soon as the pressure comes down. In these patients, obviously, if the lens has been subluxated in the anterior capsule, there's not going to be a capsule, so you will either have to do an anterior chamber IUL or a scleral fixation IUL. If there's a lot of inflammation, I would just defer the surgery and do the intraocular lens as a secondary procedure. So the next thing which we go on to is phacolytic glaucoma. In phacolytic glaucoma, the trabecular meshwork is clogged by the lens proteins, macrophages, which phagocytose the lens proteins, and inflammatory debris. The anterior chamber is deep and aqueous may contain fine white protein particles which settle down as a pseudohypopion. So in these patients, you will see a hypopion present. And then the treatment includes medical therapy to lower the intraocular pressure. So you can use oral acetazolamide, then you use beta blockers, you can do alpha agonists to reduce the pressure, and then followed by extraction of the hypermature cataractous lens with a posterior chamber intraocular lens. The thing to remember is, as there is a bit of uveitis, you need to give them topical steroids to reduce the inflammation at the time of surgery. Here you can see the phacolytic glaucoma. The macrophages are seen plugging the trabecular meshwork. There is the hypermature cataract with leaking proteins in the anterior chamber. The important thing is the capsule remains intact in these patients, and sometimes these patients even also have a Morgagnian type of cataract. And you see those white particles lining the posterior surface of the endothelium. And you control the treatment is, as we've already discussed. Then we come on to lens particle glaucoma. Trabecular meshwork is blocked by the lens particles floating in the aqueous humor after disruption of the anterior capsule. So in this case, the capsule is obviously disrupted, and the symptoms of acute rise in IOP associated with lens particles in the anterior chamber, which obviously clog the anterior chamber angle. The treatment is to lower the intraocular pressure and followed by irrigation aspiration of the lens particle from the anterior chamber. Usually, the lens is ruptured due to trauma, and the lens is usually clear and it becomes opaque at that time. Therefore, in these patients, usually you do not have to do a phacoemulsification, and the lens is usually aspirated, especially in younger patients. Then we have another entity which is called a Phacoantigenic glaucoma. It's a fulminating acute inflammatory reaction to an antigen-antibody reaction. There is a granulomatous inflammation against one's own proteins and follows disruption of lens capsule after cataract surgery or trauma within 1 to 14 days. So it's a type 4 type reaction. So IOP is raised due to obstruction of trabecular meshwork by the inflammatory reaction. So medical management includes therapy to lower intraocular pressure, treatment of iridocyclitis with steroids, and cycloplegics to prevent formation of synecdoche, followed by irrigation aspiration of the lens matter from the anterior chamber if required. Here you can see the anterior chamber, and this is the antigen-antibody reaction. Here you can see mutton fat capies on the posterior surface of the endothelium. We move on to glaucomas secondary to inflammation of the uveal tissue or uveitis, and usually it is anterior uveitis. So either it can be a non-specific inflammatory glaucoma or it can be a specific hypertensive uveitis syndrome. If it's a non-specific inflammatory glaucoma, it can be open angle inflammatory glaucoma or it can be an angle closure inflammatory glaucoma. While there are some specific hypertensive syndromes which include Fuchs uveitis syndrome and glaucomatocyclitic crisis. So those are certain entities which you know, and they have specific patterns. We'll go through open-angle inflammatory glaucoma. It can be acute open angle, in which there is trabecular clogging, trabecular edema, and prostaglandin-induced rise in intraocular pressure. Features of acute iridocyclitis associated with raised IOP with open angle of the anterior chamber, and you manage with treatment of iridocyclitis and medical therapy to lower IOP by use of hyperosmotic agents, acetazolamide, and beta blocker eye drops. This is acute angle closure, so you do not have. The other is chronic open angle inflammatory glaucoma. So this is a slow growing disease in which you get chronic inflammation of the trabecular meshwork, which is called trabeculitis and trabecular scarring. You get raised IOP, open angle, no active inflammation, but signs of previous episode of uveitis are present. Medical therapy is trabeculectomy or cyclodestructive procedures because they've already caused a damage because of the chronic nature. Then you go on to the angle closure type of inflammatory glaucoma. The mechanism of rise in IOP is secondary angle closure with pupil block, or you can have secondary angle closure without pupillary block. So clinical features include raised IOP, seclusopupillary, where there is 360 posterior synechia of the pupil to the lens surface, or shallow anterior chamber. The management will include prophylaxis, local steroids, and atropine to prevent formation of synechia, and curative treatment is medical therapy with steroids and then surgical or laser iridotomy, or you can even need filtration surgery. We go back and we see this is the angle closure in which there is caused by seclusopupillary. So you've got the 360-degree adherence of the iris to the anterior surface of the lens, causing an iris bombay. So you can see the iris is convex in appearance. So if you see the slit lamp examination, the iris is bowing forward, and here you do not see any structures in the angle, and this is called an angle closure glaucoma with pupillary block. The secondary is the angle closure without pupillary block we discussed before, which can be either due to caused by progressive synechial angle closure, while the anterior chamber is deep due to inflammation. Progressively, like a zipper, you start to get adherence of the iris to the posterior surface of the cornea in 360-degree fashion, producing posterior synechia. We move on to pigmentary glaucoma. This clogging up of trabecular meshwork by pigment particles. Patients with pigmented dispersion syndrome, pigment is released by mechanical rubbing of the posterior pigment with the zonular fibrils. Here you can see, due to the chronic nature, you can see there is slit-like defects in the iris, which are seen in retroillumination. This is typically called a moth-eaten appearance of the iris. Usually seen in young myopic females. Glaucomatous features are similar to primary open-angle glaucoma. You can see deposition of pigment granules in the anterior segment on the posterior surface of the iris in the form of a spindle, which is called a Krukenberg spindle, which is typically seen in these patients. In gonioscopy, pigment accumulation is seen along the Schwalbe's line and especially inferiorly, which is called the Sampolisi line. Iris transillumination, which I've already shown, radial slit-like transillumination defects. Treatment is exactly on the lines of a primary open-angle glaucoma. It is said you have the posterior bowing of the iris, which causes it to rub against the zonules, producing that pigment release into the anterior chamber. So here you can see the Krukenberg spindle, which I talked about. This is pigment on the endothelium, fine pigment granules on the anterior iris surface, trabecular hyperpigmentation, which is called the Sampolisi line. Then we move on to neovascular glaucoma. It's intractable glaucoma, results due to formation of neovascular membrane involving the angle of the anterior chamber. Usually it has a grave prognosis because the neovascularization is also affecting the posterior segment, because the neovascularization of the iris follows retinal ischemia, usually seen due to proliferative diabetic retinopathy, central retinal vein occlusion, sickle cell retinopathy, or rare causes such as tumors and long-standing retinal detachment. The clinical profile is you initially have a pre-glaucomatous stage, in which you have an open angle glaucoma stage and then secondary angle closure. The treatment is pan-retinal photocoagulation. So you are going to treat the retinal pathology where the VEGF or vascular endothelial growth factor is coming from, and medical therapy is usually not effective, and artificial filtration, shunt or aceton operation is needed. Here you can see neovascularization abundantly present on the surface of the iris. So causes are his ischemic central retinal vein occlusion. You see that there is venous filling, but there is no capillary filling in this patient. Long-standing diabetes, here there's capillary dropouts in this area. Central retinal artery occlusion or carotid obstructive disease, these all can cause neovascularization of the iris because the VEGF relief in the posterior segment reaches the iris as well. What you see in these patients is severely reduced visual acuity, congestion and pain. Severe rubeosis is seen on the iris over here. You've got distortion of the pupil and ectropion uveitis. Here you can see the ectropion uveitis. The posterior surface of the iris is rotated and you see it in the front. This is called, very important to recognize, ectropion uveitis. And here you can see this is the neovascularization, and the angle is closed because of secondary angle, because neovascularized blood vessels will grow radially into the angle and then they will close the angle with them. So treatment option is pan-retinal photocoagulation. Here is the artificial Ahmed glaucoma valve, or you can use a Maltino tube which you put a stent inside and drain it with a silicone tube. The main reason for using tubes in these patients is because if you do a trabeculectomy, the new vessels usually go into that area of trabeculectomy and cause fibrosis. That's why tubes are more prevalent, because the new vessels cannot grow into this lumen from the surface of the iris. The other thing you can do is cyclodystrophic procedures to relieve pain, which can include cyclocryotherapy, which used to be done in older times, in which you would freeze the ciliary body about 1.5 millimeter from the limbus in a freeze-thaw technique, or you can do a cyclodiode laser in the same area, which causes the ciliary body to be destroyed in those areas, thereby reducing the production of aqueous. Retrobulbar alcohol injection can be used in patients who have intractable pain, and because in patients with long-standing neovascular glaucoma, due to raised intraocular pressure, they tend to have bullous keratopathy, because high intraocular pressure will force fluid into the cornea and producing waterlogging of the cornea. When the water comes into the epithelium, they produce fine blisters. So that is called a bullous keratopathy. Then this is a rare entity which we'll just quickly go through, which is glaucoma associated with iridocorneal endothelial eye syndromes. There are three entities in which: progressive iris atrophy, Chandler syndrome, and Cogan-Reese syndrome. There is presence of abnormal corneal endothelial cells which proliferate to form an endothelial membrane in the angle of the anterior chamber. So this is important to know in these patients. So the features associated with eye syndrome affects middle-aged women, and progressive iris atrophy features predominates with correctopia, atrophy, and hole formation. Chandler syndrome is mild iris changes and corneal edema, and Cogan-Reese is nodular and diffuse pigment lesions of the iris. May not be associated with corneal changes. The treatment is medical treatment as open angle glaucoma, or you can do a trabeculectomy or artificial filtration with a shunt or a tube. So the classification is progressive iris atrophy, in which 100% iris is atrophied. Iris nevus, you get iris atrophy in 50%. And Chandler syndrome iris atrophy is present in 40% when the corneal changes predominate. So there is progressive iris atrophy. There are multiple holes in the iris, or there are multiple pupils. Those are called, when there are more than one pupil, that is called correctopia. And there's this, you see, iris is markedly atrophic. There's broad-based peripheral anterior synecdoche as well. So it is type of and angle closure glaucoma. Displacement of the pupil towards the PAS is seen. This is diffuse iris nevus, or you can get peduncular iris nodules. And this is the Chandler syndrome, where the initially silver endothelial changes and later edema with halos. That is the rare entity which I just went through. Another important entity is pseudoexfoliation glaucoma. This is seen fairly commonly, especially in older age group and especially in association with cataracts. So you have to recognize, usually you tend to pick it up when you see patients coming in for their cataract surgery, is deposition of amorphous gray dandruff-like material on the pupillary border, posterior surface of the iris and ciliary processes, associated with secondary open-angle glaucoma, trabecular blockage by exfoliative material, managed on the same line as primary open-angle glaucoma. So you can see a central disc, and this is a peripheral band. So here is the pseudoexfoliation material. So this is area where the iris is usually rubbing on the surface of the lens. That's why it remains clear. On retroillumination, there is defects on the iris stroma, and there is trabecular hyperpigmentation, which is a sample EC line, which is also seen in these patients in addition to pigmentary glaucoma. So glaucoma associated with intraocular hemorrhage. Hyphema and vitreous hemorrhage, usually you see them fairly commonly or in your practice, and it can be caused by different mechanisms which cause the raise in intraocular pressure. You can get red cell glaucoma associated with fresh traumatic hyphema caused by blockage of trabeculae by RBC in patients with massive hyphema associated with pupil block. You can get a hemolytic glaucoma, is clubbing of trabecular meshwork by macrophagen laden with lysed RBC debris. Or you can get ghost cell glaucoma, which is aphakic or pseudophakic eyes with vitreous hemorrhage, from where there is dehemoglobinized RBCs, their bodies present cause ghost cell glaucoma. Or you can get hemosiderotic glaucoma, sclerotic changes in the trabecular meshwork caused by iron from the phagocytosed hemoglobin. So you can see all structures of the RBC can actually cause glaucoma, either the cell itself or the macrophages which are laden with the RBCs, or the shell of the RBCs which produce ghost cell, or the iron which is released. All can cause glaucoma by going into the trabecular meshwork. So hyphema is a structure, is an entity which when you're faced with, you have to be careful to check for pressure. Here you can see the ghost cells is the RBC, the leak, the hemoglobin comes out, and this is the shell of the RBC left, which is ghost cell. Here you can see on a slit lamp examination, you see these ghost cells floating in the anterior chamber. If there's RBC, they'll be looking red, but these are typically khaki colored. And this is a patient with a hyphema. So if you see a patient with hyphema, you always check their intraocular pressure. Then we go on to steroid-induced glaucoma, is a type of secondary open-angle glaucoma which develops following topical or systemic steroid therapy. The etiology is glycosaminoglycans, which are deposited into the trabecular meshwork by using steroids for at least 2 to 3 weeks time. So it does not happen immediately, it takes some time to kick on. So symptoms are similar to primary open angle glaucoma, and prevented by judicious use of steroids is typically seen when patients go and ask the dispensers or pharmacists for anti-allergy medication, and steroids obviously a very, very potent anti-inflammatory agent. So if you give them and you use them uncontrolled, people who are typically steroid responders, which would be including patients are myopic, they will have raised intraocular pressure. Initially, the disease can be reverted by stopping the steroids, but later on it will become a permanent disease. So discontinuation of the steroids, medical therapy by beta blockers or alpha agonists, and filtration surgery if it becomes a disease which is not controlled. This is typically seen in patients with vernal catarrh because they tend to have a lot of different antihistamines being used, and eventually after being non-responsive to all these therapies, people put them on steroids and then they tend to get this entity and they can go blind because of this. Then we go on to traumatic glaucoma. So traumatic mechanism include inflammatory glaucoma secondary to iridocyclitis, glaucoma due to intraocular hemorrhage, lens-induced glaucoma due to swollen lens, angle closure glaucoma due to anterior synecdoche, epithelial or fibrosis growth, angle recession glaucoma. The management is medical therapy with topical 0.5% timolol and oral acetazolamide if required, or you can use alpha agonist and latanoprost for these patients. Surgical intervention if the pressure is not controlled. Here you can see due to trauma, the iris is separated from its root. It is called iridodialysis. And this is an entity which is called angle recession. So there's disruption of the trabecular meshwork and laceration of the ciliary body because of trauma. The iris is avulsed from its insertion. The tone zonules are seen. There's widening of ciliary bodies seen in patients on gonioscopy. So angle recession is an entity which needs to be seen in patients with trauma, especially to identify angle recession, and if they have angle recession, they'll probably need glaucoma therapy for the rest of their life. Glaucoma can also be seen in aphakic patients due to many associated things. It will go through the different scenarios, which includes raised IOP with deep anterior chamber in early postoperative period. You can get secondary angle closure due to flat anterior chamber, secondary angle closure due to pupil block, undiagnosed pre-existing primary open-angle glaucoma, steroid-induced glaucoma, epithelial ingrowth, and malignant glaucoma. I'll just show you a picture in which you see the patient. This patient is phakic with a normal lens in place. Here the patient is aphakic. So the vitreous body is convex forward and pushes on the iris. And it can cause a pupil block glaucoma. So whenever you leave a patient aphakic, you would do an iridectomy at that time to prevent this happening. Or you can do a good anterior vitrectomy to make this anterior phase of the vitreous flat so it does not cause. Sometimes this vitreous will go into the angle and then cause as well glaucoma as well. So then we go on to obviously a glaucoma which can be happening due to malignant melanoma or retinoblastoma. There is a space occupying lesion which is obviously growing into the eye and cause either trabecular block due to blockage by tumor cells, neovascularization of angle, venous stasis, and angle closure due to forward displacement of the iris lens diaphragm, and that would obviously be relieved by relieving the tumor. Here you can see leukocoria in this patient, typically seen in patients with retinoblastoma. And the last entity, which is not very common, especially with better surgical techniques, is called ciliary block glaucoma. It used to be called malignant glaucoma before. It's a complication of intraocular operation. Patients with primary angle closure glaucoma operated for peripheral iridectomy and trabeculectomy usually are seen with this, and markedly raised IOP associated with shallow or absent anterior chamber, and clinical features are severe pain, blurring of vision, followed by an intraocular operation. So here you can see what actually happens in these patients. Normally the ciliary body would produce the aqueous which go forward and go through the pupil and then drain into the angle. In these patients, this is misdirected backward. So usually when the anterior chamber becomes flat in these patients, becomes shallow in these patients post glaucoma surgery, the lens is pushed forward, thereby the ciliary body starts pushing the secretion into the vitreous, and that causes the lens to further go forward and causes shallowing of the anterior chamber, which you see, and the lens iris diaphragm is pushed forward, thereby causing an angle closure glaucoma, as you see in these patients. On examination, there is persistent flat anterior chamber, markedly raised IOP, unresponses or even aggravation by miotics. Aphakic or a patient can be pseudophakic. And the treatment is medical therapy, 1% atropine eye drops, acetazolamide, 0.5 timolol, you can use alpha agonist, IV mannitol. All things are usually needed to reduce the intraocular pressure. YAG laser hyalotomy. If you have an aphakic patient, you can go through the peripheral iridectomy and puncture the anterior hyaloid phase, and that will cause the aqueous to drain forward through it. or you can need to do an anterior vitrectomy, thereby removing that aqueous which is flowing into the vitreous. Here you can see typically a patient with post-angle closure glaucoma. There is area of iris atrophy which is seen in this patient and a mid-dilated pupil. So thank you very much for watching. I hope you've understood some part of the talk. It's a very interesting, but it's a topic which is difficult to understand, but you can go through it again, and we'll be back with more lectures next. Thank you for watching.